Hello, everybody. Welcome to the COVID Neuro webinar. This is our fifth, sixth, seventh. I can't remember exactly how many we've done now. You can see on the screen here the panelists who are going to be joining us today. My name is Professor Tom Solomon, and I'm going to share with you a few opening slides. And however many times I do this, I still don't get it quite right. Let's try that. So hopefully you can see my slides now. And if I do that, you can tell me whether you're seeing one slide or lots of slides. You're seeing just the one slide. Do I need to flip my screen? Are you seeing one slide or are you seeing the whole presentation?
Seeing the whole presentation at the moment.
Okay, so I have to swap display. There we go, that's better. Great, so this is the COVID Neuro webinar. One day we'll count them up and see how many we've done, but it's been quite a lot. We do it every month. This time we've got from Christian Medical College in Vellore in India, Priscilla Rupali and Ajit Sivadasan. Say hello, guys. There they are.
Hi.
Then we are, by popular demand, we're having the short interlude. It's not a musical interlude, but it does, and it's not an advert. It's not quite a commercial break, but we're having the short interlude where this time Jamie Badnock, who is from the University of Birmingham, is going to give us the highlights from the COVID Neuro blog, the JNNP blog. Say hi, Jamie. And then Mike Zandi is also then going to join us from University College London. So we're hosted by the Global Health Network, which is a brilliant knowledge exchange platform with over 300,000 members and with 40 interlinked communities of practice, as they are called. And the network provides training and professional development, all in relation to global health research. As well as the Zoom webinar, some people are watching this via Facebook. We want you to get involved. You can send in messages via the chat function or the Q&A tab. If you send in messages on the Facebook pages, they'll be translated over so we can see them here. You can tweet. My Twitter is @RunningMadProf, so you can send in messages via that route as well. And to check the chat function is working, we'd like everyone to just type now your name, where you're calling from, whether this is your first webinar or whether you are a repeat offender. And you could also tell us what you think of the, no, maybe not. I was going to say what you think of the American election, but maybe we'll save that for another day. I'm a neurologist based at the Walter Neuro Centre in Liverpool, and I'm also a researcher at the University of Liverpool, where infection is one of our strengths. I head the Brain Infections Group, which covers a range of relevant disciplines on brain infections, and these are some of my senior colleagues. We've been running Brain Infections Global for some years now through the Global Health Network, and it is a collective of researchers studying brain infections in various locations. It also includes some training packages, which we operate through the Global Health Network. You can see we have more than 20,000 visitors to the, well, we need to update this slide now. Anyway, lots of people are members of the Brain Infections Global Network, and we've had more than 3,000 people taking our free online Neuro ID e-learning courses, so you can come back and do those at your leisure, especially those of you who are in lockdown and are looking for things to do because you can't go out in the evenings. Also on the Brain Infections Global webpage, there's the COVID Neuro pages. We set these up quite early on in the pandemic. There's the COVID Neuro resource, which is the latest publications on neurological disease related to COVID. But also at this point, I'll point you to the JNNP blog, which again is another resource of publications relating to Neuro COVID. And these include little commentaries about what's good and what's bad in the papers. And the JNNP blog team are going to provide the commercial break in the middle. And then also we set up the COVID Neuro Network. So this is a network of researchers who are collaborating, collecting data on their patients with neurological disease associated with COVID-19. You can download the case record forms from the network, they're free. These are now, we've worked with colleagues to form WHO case record forms, and the adapted ones, which are slightly different, which are the official WHO ones, will be going up on there sometime soon. Ava Maria, get back to me about that, please. We published early on a literature review of all the publications to date on neurological associations of COVID-19. And having identified all these papers and all these groups working in this area, we decided to collect all the data for an individual patient data meta-analysis. And again, people who have collected data on the case record forms can contribute to this analysis if they wish to. So far, we've got data on about 2,500 patients from 78 different centres. In addition to this, we're part of the UK network of centres that are collecting data through a UK study called CoroNerve, but the slides I've got here are very much from a global perspective. Anyway, let's get on with today's talks. So the first presentation today is coming from CMC Vellore. I'll stop sharing my screen so those guys can get their slides up. And it's a great pleasure really to have the Vellore team with us today. I've known Priscilla Rupali for many years now. She's a very close friend and strong collaborator working on infectious diseases at CMC Vellore, and she's going to present along with Dr. Ajit Sivadasan, who's the professor in the Department of Neurology there. So I'll hand over to you guys. Thanks very much.
Thanks, Tom. And can everyone hear me?
Yeah, we've got you loud and clear.
Okay, great. So greetings to you from Vellore, which is a tiny town in South India, but has 500,000 people. We are a tertiary care center. We see quite a few patients. Our outpatients are about 9,500 per day, and we have about 2,900 beds. So this is, I'm just going to give an introductory thing about our COVID work, and then I'm going to actually hand over to Ajit for the actual interesting case. So this is nothing new to you, all of you, and now that the world is nearing the 50 million mark, India has also been affected quite a bit, and we are still dealing with the aftermath of it. And this is from Tamil Nadu, the state I come from, and as you can see, we were hit quite badly. And these are the number of samples that were tested and the number of positive cases that we've had so far. And as you can imagine, at this, we actually encountered quite a few patients in our center, even though we are far away from the metropolitan city of Chennai. So this is in CMC Vellore, and these are the number of cases that we've tested. We've looked after more than 10,000 patients, and this is still yesterday. So these are the inpatients that we saw. So we celebrated too prematurely. In March, we were like, oh, we're probably not going to see it. And then slowly it began, and it really hit us in July. And we seem to be on the downswing at the moment in November, but then considering that UK is seeing a second wave, we don't know when our second wave is supposed to arrive. So I'm just going to go through the challenges that we faced. As a private institution, we were not really allowed to test till March end. PPE supply chain or personal protective equipment was not assured as supplies ordered and paid for us were actually being routed elsewhere, widespread anxiety among various levels of staff. There were lots of mutinies because, as you know, social media is now widely available. So, and of course, monitoring, rationing, and maintenance of a supply chain of N95 masks led to a lot of unhappiness. And of course, in March, we were facing uncertainties about treatment regimens, and as you can imagine, it's no news to anybody, but preprints, non-evidence-based treatments, all available in literature, lots of expert opinion, and that led to a lot of angst and confusion. So this was our team. Actually, we started out with HICC assuming the incident command, becoming the incident command center based on the medical superintendent's office. HICC is our hospital infection control committee. Unfortunately, as the deputy chair of HICC, we were actually, we had a major role to play. And what did we do and how did it impact us? So initially, luckily, I must say, Tom, this is right after the Malawi meeting for BI Global. On the flight, I noticed a lot of people en masse, and I came back and I was kind of convening a meeting of our Hospital Infection Control Committee, and we decided, okay, we need to be prepared. And so we actually set out making teams, triaging Till February, we actually had 9,500 patients every day. In fact, right up till March 24th, when India went into a lockdown. We needed to put in teams very quickly together. And of course, the major part of it was infection prevention control, environmental disinfection, engineering controls, and the clinical treatment group, which, by the way, I must say, BAG was a very important part of the clinical treatment group. We were a good group which worked well together, sifted evidence rapidly, and ended up making guidelines as well. This was our PPE committee, which met regularly. We did our modeling and then went out to actually deploy and follow up supply and stock. So required a rapid multiple protocols that we had to put into place depending on how the supply chains were, as well as the number of cases that we actually saw. So this is just some of the pictures that I captured of the various things that were being done. I'm sure you would have never seen a picture like this in India before, the physical distancing, but it was amazing how people banded together to actually help us get through this pandemic. These are the moment pathway sorted out. I think we made about 500 protocols. We had to rapidly ramp up our engineering capacity. As you know, we don't really have negative pressure rooms, so we had to come up with indigenous solutions. And of course, the clinical group, which we met twice a week. First meeting was actually on 19th March, twice weekly meeting to discuss clinical treatment updates, etc. And we went on to actually make treatment guidelines. A lot of work actually done by, I must say, a lot of credit to BAG as well. We were a close-knit group which actually rapidly upped the guidelines with regard to COVID-19. So this is the summary of decisions. This is the process that we went about, and this is how our guidelines actually look. So this is just flavor of what we went through in CMC Vellore. And now on to the interesting things that we actually saw. I'm going to actually hand over to Ajit to share his slides and present a couple of interesting cases that we came across while dealing with COVID-19.
Thank you, Dr. Priscilla and Professor Tom, for inviting us. So I'll go on to our experiences as a neurology unit. So this is regarding the spectrum of inpatient admissions, which were under neurology and under general medicine with predominant neurological manifestations. So we had around 37 patients over the last 2 months, August till September 2020, over a period of 8 weeks, which included around 3 patients with Guillain-Barré and CIDP, 3 patients with myelopathy, 9 patients with acute encephalitic syndrome and acute encephalopathies, 8 with cerebral venous thrombosis, and around 13 with arterial stroke. Interesting to note that 2 patients with acute encephalitic syndrome also went into rhabdomyolysis even right at the time of admission due to recurrent seizures or a concurrent involvement of the muscle by COVID as well. And 3 patients with stroke actually went on to require decompressive craniectomy and recovered fully at the time of discharge. Regarding the spectrum of arterial strokes and COVID infection, the mean age of stroke was younger, 44.3 years. It was 72% of the population actually had young strokes, age of less than 50 years. 78% of the population was male. The median age of the range of duration of onset of stroke from the onset of symptoms related to COVID-19 was 7 days, from 1 to 14 days. Nearly 78% had evidence of large vessel occlusion, and 86% of them had moderate to severe COVID infection, again indicating that it is very likely to be causative rather than coincidental in this setting. So going on to a couple of interesting cases. The first case is a 63-year-old gentleman, a known diabetic who was admitted with severe COVID infection and hypoxemia. He came to us 3 days with an onset of symptoms. He had very high inflammatory markers like ferritin as well as D-dimer around 15,000. And he was admitted, he was started on dexamethasone and heparin. His oxygenation was improving. But on day 2 of admission, that is day 5 of onset of illness, he developed acute paraplegia with a sensory level at T10. And over the next 3 days, by day 5 of admission, he also developed bulbar dysfunction with severe pooling of secretions. And we had done a scan at this time, which shows a longitudinally extensive transverse myelitis, almost extending from C6, C7 up till the conus. There is involvement of the brainstem also, the left MCP, the left pons and medulla, which was not restricting on diffusion-weighted imaging. And there was a mild peripheral ring of enhancement. So overall, the clinical as well as radiological features were suggestive of parainfectious demyelination in the setting of a COVID-19 infection. His CSF analysis was done, which showed only 28 cells with a elevated protein of 173 milligram percentage and a glucose of 159. His CSF RT-PCR for COVID-2, SARS-CoV-2 was negative, and the other virus PCR, multiplex PCR was also negative. All his cultures were negative. His serum interleukin level was mildly elevated, 11.6, the reference range being less than 7. However, CSF interleukin level was markedly elevated, around 2,672 picogram per milliliter. And we went on to do a CSF antibody with a concurrent serum antibody with the help of virology department. And he had the antibodies to both total IgG to the receptor binding domain of the S protein as well as the nucleoprotein of SARS, IgG antibody positive in both serum as well as CSF. So what is unique in this case? One is the co-presentation of neurological complications with respiratory symptoms early in the disease. Most of the literature is regarding after recovery of the respiratory illness, almost in the second or third week of illness. Here, as early as day 5, day 3 of illness, the patient went on to develop a myelopathy. There was definite evidence of an intense virus-specific intrathecal antibody response with markedly elevated interleukin-6 levels in the CSF. And we also went on in a case-based scenario, we went on to check the cycle threshold in this patient in the nasopharyngeal swab, which actually showed that he had a relatively low virus load, a cycle threshold value of 31.1. So this was very unique in this case. So some of the learning points from this case include that how early can antibody response be seen? Literature says that though it's usually seen after 10 days, sometimes you can have very early antibody response within the first 3 to 7 days. But what could be more relevant is the phenomenon of what is called immune enhancement or antibody-dependent enhancement. What happens here is that the virus particles get opsonized and there is binding of the IgG antibody to receptors on mononuclear cells, which actually potentiates the infection and leads to more of a release of pro-inflammatory cytokines. And in this setting, in this patient who had severe SARS infection as well as an early and very high antibody response, we don't know how much of it could be like a cross-reacting antibody with other non-SARS coronavirus. This we could not establish in our laboratory. This patient was started on intravenous immunoglobulin. However, he developed anaphylaxis to that, was subsequently given pulse dose steroids. He had a very turbulent course in the hospital and developed a nosocomial sepsis as well. This is the second case. This is a 37-year-old gentleman who was admitted in September 2020 in our hospital. He had a prior admission in Chennai, the nearby metropolitan, with severe COVID and ARDS in July 2020, at which time he required non-invasive ventilation as well. He received steroids and enoxaparin there and his respiration stabilized. He didn't require any ventilation. However, during the course of same hospitalization, he developed pancytopenia and ferritin values documented as high as 1.5 lakhs. And his bone marrow done in the outside hospital was consistent with the hemophagocytic lymphohistiocytic syndrome, the HLH. There he was treated with intravenous immunoglobulin, dexamethasone, cyclosporin, as well as etoposide, and he was discharged up and was discharged in the first week of August and was stable for the next 3 weeks after discharge. And we also had documented viral screen for Epstein-Barr virus and cytomegalovirus done in that center, which was negative. So he came to us on around 20th of September, but this was the course of deterioration over the 3 weeks after discharge. 3 weeks after discharge, on 22nd of August, he went on to develop left lower limb calf pain with weakness. By the 3rd of September, he went on to develop a drooping of the left eyelid with diplopia. By 10th of September, he went on to develop right lower limb, eventually becoming paraparetic. And on 14th September, that is over a period for around 3 to 3.5 weeks, he went on to develop distal hand weakness as well as bulbar dysfunction. And when he came to us, he had bulbar dysfunction as well as quadriparesis, which was more of a floppy element type, and also had new onset headache with multiple episodes of vomiting. So overall, the features were suggestive of a craniospinal disease with arachnoiditis. There was evidence of dural as well as leptomeningeal enhancement as seen by enhancing cavernous sinus as well as the enhancement of the lumbosacral roots consistent with the diagnosis of arachnoiditis. His cerebrospinal fluid was done, which showed 180 cells. The CSF appearance was xanthochromic, and it was showing both lymphocytes of 51% as well as monocytes of 30%. Sorry for the typo there. And CSF smear actually showed foci of macrophages with hemophagocytosis. His CSF sugar was normal. Its multiplex PCR for multiple viruses showed positivity to EBV. However, the IgM for anti-EBV capsid antigen was negative, ruling out an acute infection. The other markers like for HLH, like CD25 assay, was normal. His ferritin had come down to 1500. His triglyceride was normal. We repeated a bone marrow, which did not show any evidence of HLH. in any case of HLH, it's important to rule out, though there could be secondary triggers like autoimmune diseases, lymphoreticular malignancies, and viral infections as well. It's important to rule out that there is no background of a genetic disease which predisposes to HLH, which occurs with perforin mutations. The genetic panel for HLH was also done in this case, which was negative. So the final diagnosis in this patient was that of a polyneuritis cranialis with arachnoiditis and meningitis being the clinical syndrome. He actually presented to us with a secondary hemophagocytic lymphohistiocytic syndrome. And what he came into with is an isolated CNS relapse. The systemic parameters had improved. However, he came in with new onset meningeal involvement and cranial nerve palsies and paraparesis and had unequivocal evidence of a CNS relapse. This was most likely related to the setting of COVID-19 infection. How do we interpret EBV here, which was positive in the CSF? It is more likely related to a reactivation, which could be related to the COVID-19 infection itself, the immunosuppression which the patient had received, as there was no definite evidence of a EBV acute infection because the IgM viral capsid antigen was negative. And there was an isolated report from Pittsburgh also in which they actually had a combined EBV. EBV is actually implicated in a lot of cases of HLH, and as we all know in CNS lymphoproliferative disorders also. So there could have been a synergistic viral association also in this case. And so what is the pathogenesis of HLH? It is related to a hyperinflammatory response in the cytokine storm, which is well described with COVID. And eventually, because there is persistent activation of the cytotoxic T lymphocytes, the natural killer cells, as well as macrophages, there is gross invasion of the marrow presenting pancytopenia as well as tissues, leading on to organomegaly as well as CNS involvement. It is very important to identify CNS involvement here because unless you treat it very early and with a multimodal approach, the recovery tends to be, this can be a potentially fatal disease. And because of this, in spite of this inflammation, this is actually a dysregulated immune response. There is an inability to clear the viral infected cells. There is elevated interferon gamma as well. So this patient, in addition to systemic chemotherapy, was also started on intrathecal methotrexate and steroids, and also ruxolitinib, which is a selective JAK inhibitor, which is used in the setting. Though the EBV was equivocal, we didn't go ahead with rituximab with this patient as a B-cell depleter. And we were happy to note that by the time of 3 to 4 weeks in hospital, he had complicating sepsis, but he was, due to the immunosuppression, but was ambulant with minimal support. He had come to us with quadriplegia and bulbar involvement. So with this, I conclude my slides. Again, and thank you for this opportunity.
Thank you. Thank you both. Thanks very much for giving us the situation in southern India, and then also for those great presentations. So if you just stop sharing your screen now, Ajit, yes, and I'd ask people to post any questions or comments or share with us your thoughts. You can post them into the chat function, or you can put them on the question and answer, but the chat function is best. Maybe I'll start with the Ajit, with this first case that you presented, who you put them onto dexamethasone, and I was interested in the timing, in the sense that, was this timing in terms of where this was in the pandemic? I mean, we now put everyone on dexamethasone if they're needing oxygen because we know they have a better outcome. Was that why this patient was put on the dexamethasone, or was it before those data and because you wanted to treat the myelitis? Over.
No, the dexamethasone was started for the ARDS which the patient had at presentation. He had multiple chest infiltrates and hypoxemia at presentation, for which he was started on dexamethasone. And almost on the late second day of admission was noted to have an acute paraplegia, at which time, in addition to dexamethasone, initially intravenous immunoglobulin was started. However, he developed an allergic reaction to it. And then we changed over after receiving the third day of dexamethasone, we changed it actually over to intravenous pulse dose methylprednisolone. That was the course of things.
Thanks very much. Now, also, so we're going to do something slightly different this time, as well as people posting questions. We've noticed that we've had some very eminent people joining the meetings as time has gone on. And so if any of those people would like to just comment on the cases that we've heard about, then please let us know. Avi Nath has joined us again for the call. Avi, I've messaged you because I didn't want to put you on the spot, but I'm not sure you've seen the message. But if you'd like to comment on perhaps especially the second case, I'd be really interested to get your take on that. I think I saw Rob Haderman as well was on the call, and Emma Wall and Tom Pollock. If any of those guys would like to share their thoughts on some of these complicated cases, then please do. Go ahead, Avi.
Sure, Tom. First of all, I wanted to say I'm very impressed with what you put together. That global network there is an incredible task that is going to be very valuable to all of us, and I want to congratulate you for your efforts. These two cases are really fascinating, and certainly I'm happy you comment on the second case. What I missed was, Ajit, did this patient, were you implying, got reinfected at the second presentation with COVID, or this is just a prolongation of the first one, or is it independent of the first infection?
No, Professor Avi, he had actually recovered from COVID and had come to us with he was stable for 3 weeks after discharge. He had presented with a COVID ARDS, had completely recovered from it, at which during the same course of hospitalization, he was detected to have pancytopenia and HLH, systemic HLH, was started on immunosuppressants for the same and discharged hematologically stable and came to us 3 weeks later with an isolated neurological relapse, which in the form of, yeah.
So it's very interesting. We published a patient in December issue of Annals where there was the question of CNS HLH in a patient with aplastic anemia. And at that,
oh God. Sorry, Avi, that was me. I'm sorry. I tried to make it so you can turn your video on as well, and I think you need to just turn your video and voice on.
Oh, okay, yeah, here you go.
Apologies.
Right, now
great. Now we can see you. Fantastic.
Quarantined here in my house. Okay, so there, unfortunately, what happened was these JAK-STAT inhibitors can be so immune suppressive. This patient developed a JC encephalopathy. The entire brain became edematous, and we looked at autopsy. There was just virus everywhere. It was not just demyelination, it was in every single cell type. So here, I'm very fascinated. This patient actually did fairly well, although the patient developed sepsis. What was the ultimate outcome of this patient?
Right now, yesterday he has developed a gram-negative sepsis for since the last 2 days. He has gone on to ARDS and has been shifted to the ICU for monitoring. He had a neurological involvement, but like his lungs have gone down because of a secondary infection.
Yeah. That's the challenge in treating these patients. You know, you protect one thing and then another severe problem can arise. All right, great, thanks.
Thanks, Avi. Sure. Rob Haderman from University College London had a question. Rob, I've made you into a panelist, so if you want to turn your video and voice on, you can do so. But if you're in the middle of decorating the kitchen and you don't want to, no, there he is, there's Rob. Go ahead, Rob, good to see you. Please ask your question.
Thank you. So I'm not at home, but actually at work, Tom. So what I'd be interested in the second case is, do you think there was indeed a persistent CNS viral infection with SARS-CoV-2? And did you contemplate using antivirals? I think particularly in relation to the sort of previous comments around using really quite profound immunosuppression.
Yes, during the first, he was managing a corporate hospital in Chennai before he came, when he had the systemic HLH, at which time he was given a course of ganciclovir as well. The exact reason for that is not sure, but the viral screening outside was negative. So I think he had already received remdesivir for the COVID. But by the time he came to us, the second episode looked more like a CNS inflammatory response, like a hyperinflammatory response. He didn't receive any antivirus the second time. We had gone up with just immunosuppression. And we had just boosted the immunosuppression. He was already on etoposide. He had received intravenous immunoglobulin just around 3 weeks ago. And we had just gone up with intrathecal dose of methotrexate as well as steroids. And added on it was predominantly done by I should acknowledge, we had a very good backup in the form of a hematology department here, who had advised us to start the JAK-STAT inhibitors as well and had taken him over. The initial 3 weeks after starting all these medications was really fulfilling because he had a good neurological involvement with the doctor by profession himself, ENT surgeon, and actually started walking. His bulbar had completely improved, but just the last 48 to 72 hours, he has not been doing particularly well. We have an isolation, probably he'll isolated culture growth, so probably he'll become better with antibiotics.
Okay. We're gonna move on. Thank you very much, Rob. Just if you could give a very quick answer, Ajit, to this question that's come in via the Q&A from Vanshika Singh. which says, so brief answer if you can, could you elaborate on the relation between immune enhancement and bulbar involvement?
In the patient of para-infectious ADM, which we had discussed, the bulbar involvement was likely related to the spectrum of illness itself, because had a transverse myelitis and a patchy lesion in the brainstem as well. The reason why we brought in a proposed concept of immune enhancement in that patient is because he has a very early significant antibody response. And actually, we had, with the help of virology, done a quantification also there. So it was just a concept, and approximately the same time, the problems regarding the Oxford vaccine had also come up. So it was just a postulate. We were not able to prove it actually.
Okay, brilliant. Thanks very much. So thank you again to the CMC Valor team. We're going to move on now. Jamie Badnock is going to share his screen. He is at the University of Birmingham. He's actually a final year medical student, and he's part of the team under Tim Nicholson working on the JNNP blog. So again, the challenge to Jamie, I think we give him 5 minutes to talk about maybe 3, 4 or 5 publications that have caught his eye. Go ahead, Jamie.
Thanks a lot, Tom. Yeah, so as Tom said, good afternoon, everyone. I'm Jamie Badenoch, and I'm actually just presenting 3 papers today, which all stood out to us whilst we were curating the literature on the neurology and neuropsychiatry of COVID. So these are all recent articles which have featured in our blog highlights. So it's obviously important for us to ascertain the makeup of neurological complications in COVID to improve the detection, prevention, and management of these manifestations, which have great potential consequence. And there have been several large-scale epidemiological studies which have sought to do this. So in this one, the authors conducted a retrospective case note analysis to evaluate the prevalence of neurological manifestations in nearly 2,000 consecutive COVID inpatients. So they found that 7.8% reported neurological manifestations. And similar to Ajit's data and to the data of other epidemiological studies, cerebrovascular accidents and altered mental status were by far the most common manifestations. So amongst those with cerebrovascular accidents, 37 were ischemic and 11 were hemorrhagic. And in terms of the altered mental status, this was not further evaluated except for 5 patients who had an encephalitis. And for the remainder, we can only assume that they were delirium or encephalopathy. And this is of current relevance due to the ongoing debate, which was really propelled from the coroner study about how to classify and characterize altered mental status in patients with COVID. The retrospective approach they employed and the non-systematic screening of patients for altered mental status likely means that this is an underrepresentation. So the prevalence of overall neurological manifestations was lower than in other papers, and this could be due to the study methodology. For example, to be classified as a neurological manifestation, the patients had to undergo neurological evaluation, whereas in contrast to the Mauertel study, which found a significantly higher prevalence, any mention of a vaguely neurological symptom in patient notes was included. So the question of how prevalent these manifestations are remains unanswered, and really we need prospective and longitudinal data to answer this question. Despite this, our group is near to completing the first iteration of a systematic review and meta-analysis to analyze this very question. So as I previously mentioned, altered mental status, including delirium, is a common finding in COVID. And this is especially true in patients admitted to ICU. The biological basis of this has not been elucidated. So I included this paper as it's one of the few studies to explore the etiology of delirium in COVID. And it also included a non-COVID-19 critically ill control group. So the authors sought to quantify blood-based biomarkers of neurological damage and determine if these markers were associated with delirium. So how did they do this? They measured the concentration of 4 non-specific surrogate markers of neuronal and neurovascular damage, and they did this in 27 ICU COVID patients and compared it to 19 ICU controls. What were their main findings? So compared with ICU controls, GFAP was 2-fold higher in ICU patients with COVID. The second main finding, they found significant associations with 3 of the biomarkers and delirium in the COVID group, but not in the ICU controls. So really looking at this from a general point of view, it's preliminary evidence for a role of biomarkers in COVID-19 delirium. However, these findings are limited by not only the small sample size, but also the small effect sizes, and that the control group was only partially matched. So although the study design cannot infer causality between the biomarkers and COVID delirium, it is nonetheless important by suggesting that acute neurologic injury could be a driving force behind altered mental status in this patient group. However, it's still important to consider the psychosocial factors underlying delirium. So although there have been reports describing altered mental status and cognition changes in acute COVID, there is less research evaluating cognitive problems post-infection or in more mild disease. We all know brain fog has been widely reported in grey literature, and it's reasonable to suggest that mild or more subtle deficits could exist. So the authors of this study interrogated cognitive performance from a large sample of the general public, and they compared results from those who had recovered from COVID with those who had never reported the illness. To do this, they collected comprehensive cognitive test data on the back of a BBC Horizon project, quite a novel study design. And people who had recovered from COVID exhibited significant cognitive deficits, and this still held true when controlling for a range of potential confounders. So interestingly, there was a substantial effect size for people who had been hospitalized compared to those who hadn't, and this was particularly true for patients who were put on a ventilator. There was also, and just in terms of what these numbers mean in clinical significance, so a decrease in half a standard deviation was equivalent to a 10-year global decline in cognitive performance. There was also, importantly, a significant decrease in cognition observed for patients with more mild disease. So in general, the deficits were broad. They affected multiple cognition domains, but primarily semantic and visual selective problems. The implications of this study are limited by the fact that only 361 had a laboratory-confirmed COVID diagnosis. However, they're nonetheless important in demonstrating the potential presence of cognitive deficits in long COVID. So thank you all for listening for the whistle-stop tour of these three papers. I just wanted to say that if you fancy joining our ever-expanding team, please email Tim Nicholson, or you can direct message us on Twitter. So thanks a lot, Tom.
Thank you very much. That was great. Thanks, Jamie. So we won't take any questions at that point, because we know if we do, we'd be here for 3 hours. But the papers are all there for people to go and look at. So if you want to stop sharing, and then next we'll have Mike Zandi, who is going to give our last talk today. Mike is a consultant neurologist at the Queen Square in London, and he's also an honorary professor of neurology at University College London. And he's conducted a range of projects on encephalitis, and now also in particular is looking at COVID neuro. Thanks.
Thanks so much, Tom. And everybody, can you hear me?
We've got you, yeah, we can hear you
loud and clear.
Your slide, so that's perfect.
Fantastic, thanks. So I'll be fast, so in 10 minutes. So I'm going to talk about COVID neurology, which you're all familiar with, and also what can encephalitis lethargica teach us. And of course, you will all know, this audience know very well, that the neurological symptoms have been described since Wuhan first reports, also Strasbourg reports early on. The virus has the ability to infect the brain and is neurotropic. However, many of the features that we've seen, we haven't seen clear evidence of brain infection. And not only have we seen neurological effects of COVID, there are also the neuropsychiatric features and psychiatric, and there's a great overlap and many challenges, particularly as we start to deal with people who've had COVID and have lingering symptoms over months. What is neurology and what is psychiatry, and what's the best approach there? We're very pleased in UCL to be part of your group, Tom, and as part of this national and international effort led by you, Ben Michael, and also you've mentioned CoroNerve with Rhys Thomas, Ian Galia in Southampton, and this has really shown the strengths of collaborative working, and also part of the UKRI funded COVID CNS follow-up study for hospitalized patients. And we also want to keep our links with European colleagues and colleagues internationally. It's fantastic to see this, the work from India today. So in July, we reported what was going on in London and linked hospitals in terms of our own encephalitis MDT. So for the past 4 years, we've been a group of neurologists and infectious diseases doctors, including a few on the call today, like Emma Wall and Rob Hademan. And with my close colleague Hadi Manji, who has a background in HIV neurology, and you'll know, we've had this interest in infections or the immune system causing encephalitis, and we'd meet once a month in person and discuss difficult cases from around the country. And in March, with the first wave of the pandemic, we decided to close down the meeting. Many of the fellows running the meeting were redeployed clinically, and we thought nobody would be interested in obscure and rare diseases of brain inflammation. But within a couple of weeks, we were having notifications from our colleagues in the district hospitals related to Queen Square around London, but also in the region and in UCLH in Queen Square itself, that we were seeing patients who'd had COVID who were manifesting with some severe neurological features, some of which were consistent. And we saw 5 main patterns at that stage. The first was a group of patients with encephalopathy. And I know Tom Pollock is on the line here. You know, the definition of encephalopathy versus delirium and what is, and also you, Tom, you were in a webinar earlier this week. There are challenges in making this clinical diagnosis. And I suppose one of the things to flag up for our data set here is this is very biased. This reflected tertiary cases referred to neurologists and then referred to a specialist center to try to define these cases. And so with some circular definitions, we defined patients in this group generally by having normal brain imaging and they would have transient symptoms, and those were the groups with an encephalopathy. But of course, and as Jamie has just presented very well, in time, what are the long-term cognitive effects on these patients? This is of critical illness. We then saw patients with CNS inflammation, stroke, peripheral neuromuscular features, which I'll show in the next few slides, and a 5th group of miscellaneous problems related to COVID. And here we've seen optic neuropathies, pseudotumor cerebri with raised intracranial pressure, cranial neuropathies, and a range of things. We're seeing some vestibular syndromes. And these are patients that we're looking at in detail more now. So for the patients with CNS inflammation, we saw, for example, in the top row, a few patients who had features of a typical limbic autoimmune encephalitis post-COVID, and they had no features of CNS infection, or at least we found no evidence of the virus using PCR in the spinal fluid. And you would see memory disturbance, sometimes psychiatric features, and you can see in at least this first patient very typical MRI findings, for example, that you would see in the LGI1 antibody-associated encephalitis. In those patients that we saw, we didn't find those antibodies, but there now have been reports of NMDA receptor antibodies in patients after COVID. And then you can see in this second panel here, a patient who was very slow to wake up from the intensive care unit, who had severe respiratory COVID and went on to have MRI. And you can see here large white matter lesions. And we saw several of these patients who would really have features consistent with an ADEM, an acute disseminated encephalomyelitis. And although you can see super added dark lesions within these areas. And so there seems to be a pattern that we were seeing that was quite specific for COVID, although has been seen after previous viruses in the literature over the past decade or so. And this is the wrong axial sequence here, but we would also see microhemorrhages and lesions in the splenium of the corpus callosum. So there are some features that look very typical of COVID, but not 100% specific. This last patient in 2 rows had acute necrotizing encephalitis. And so whether or not there was viral infection of the brain as part of this is unclear, and they didn't have a post-mortem to show that. This is one patient who had a hyperacute ADEM with many features of the Western Hurst hemorrhagic leukoencephalopathy. We didn't see hemorrhage in the susceptibility weighted images or in the biopsy, but this was a young woman who had very mild respiratory COVID, did not need to be admitted to hospital, and then presented a week or so later with headache, somnolence, progressive left hemiparesis, coma, fixation of one pupil, and needed decompressive craniectomy rapidly to allow the brain to swell. And a few weeks later, I saw her on the ward. A few weeks after that, she's almost back to normal. And then here we had a patient who had combined central and peripheral disease with many features on the imaging of a leukoencephalopathy that was transient and did respond to steroids. So this was from one of Ross Nortley, Dr. Ross Nortley's patients. These are our patients with strokes, and Laura Benjamin between Liverpool and UCL is part of this group. And we would see patients who had severe ischemic stroke. Half of the ones we saw also had pulmonary thrombus, and you can have stroke even in the presence of already the patient being anticoagulated with markedly elevated D-dimers. So this does appear to be relevant to the recent COVID. We'd also have patients who would have, say, an isolated seizure, but could have a brain that was full of these microhemorrhages. In terms of Guillain-Barré syndrome, we did see Guillain-Barré syndrome after COVID. In many of the cases, it wasn't absolutely clear that the COVID was the cause of this. And in fact, epidemiologically, and this is work by my colleague Mike Lunn and Steve Keddy, that is not yet out, that is out in preprint form, we've seen fewer cases of GBS, at least in England, compared to previous years. This is the first wave of COVID in England, and this is the incidence of GBS in the different months over these years. Now, there are so many different confounds here. Maybe patients didn't present to hospital. There were obviously a lot of deaths from COVID. And there are patients on the ITU who may be profoundly weak, and a GBS may be missed. Similarly, other viruses and transmission of causes of GBS were reduced due to lockdown measures. However, we haven't seen a vast epidemic of Guillain-Barré, of hospitals inundated with people paralyzed after COVID, given the numbers of patients who've had the infection. And therefore, we think it's unlikely that there's going to be a large association with Guillain-Barré syndrome. In terms of the neuropathology, this has lagged behind in terms of the brain compared to other organs. It's been difficult to get good brain sampling. In one of our studies, we have seen in patients who've had stroke and died of severe COVID, this is led by Sebastian Brandner, evidence of a microangiopathy and ischemic changes. And again, so far we hadn't convincingly seen viral infection, though this has now been seen by other groups. So this is from Igor Koralnik and Ken Tyler in Colorado. We know that systemic disease can cause neurological symptoms. We have seen an excess in our own group of what we think is post-infectious immune-mediated involvement. But of course, there is the potential for CNS infection. And I saw in the questions the effect of hypoxia needs to be studied. And we didn't include, or at least in detail, look at in our patients, those who had critical illness neuropathy, though I recommend looking at a preprint and study by Steve Saucer, Ed Needham, David Menon and colleagues in Cambridge who've seen an excess of peripheral nerve vasculitis, what looks like a microvasculitis and ischemic changes in peripheral nerves, beyond what you'd expect for compressive and other forms of neuropathy. And of course, we've heard about the raised interleukin-6 and other signatures, and we haven't really seen a significant utility of that marker to help diagnose neurological disease per se, but of course we need to study these biomarkers. In terms of the mechanism, there's so many studies coming out now, it's really hard to keep up, and also how to deal with preprints, which are then in the public realm, haven't been formally peer-reviewed, but at least you can see this fast. This is one study which I particularly like from Akiko Iwasaki in Yale and colleagues, and you can see builds on the work that's been done in Zika, which you've been involved with, Tom, where we know these brain organoid models are very good at modeling viral infection. So SARS can infect brain organoids. This can be rescued by the antibodies that are seen in spinal fluid from patients who've had CSF. In 3 patients who died, 2 with severe COVID, the virus has been seen in the cortex of the brain. And in terms of mechanism, one interesting finding is the type 1 interferon signature isn't seen in the brain as it is seen in the body, though there's this curious effect that infected brain cells seem to choke off the oxygen delivery in adjacent brain cells, which is very interesting, albeit in a Petri dish. And you see this through raised hypoxia-inducible factor. So what of the long-term features of COVID, the long COVID symptoms? Well, we're very interested in this too. And we now have a funded clinic from the National Brain Appeal led by my colleague Patricia McNamara, who's also a specialist in autonomic disturbance. And she and I are seeing patients, but among a group of colleagues involving neuropsychiatrists, physiotherapists, allied health professionals, and embedded within the infectious diseases service. But we are also looking at those patients who need further, more detailed neurological workup. And it remains to really be seen how the virus and the illness can cause long-term effects. And of course, that's something that we're all studying now. So the second part of my talk, or really the question, is what can we learn from encephalitis lethargica? Well, first of all, what is encephalitis lethargica? This was this epidemic that occurred from probably 1915 or so until 1928 or potentially later, of 4 forms of disease, and of course very closely linked to the 1918 influenza pandemic. And so this is great temptation to draw parallels there. And you'll see the most common form described by von Economo, who was in Vienna, and he was looking at lots of patients who were coming back from the First World War with brain injuries, but he was picking out those patients who were particularly somnolent. So there was a somnolent ophthalmoparetic form, with some patients who had a flu-like illness, sore throat, fever, myalgia, and then we'd be followed by dramatic somnolence and coma and with ophthalmoparesis. A second form, less common, is a dyskinetic form, and then rarely an akinetic or astatic form, which he described, which is the post-encephalitic Parkinsonism. And this is taken hold in the public imagination too, and many people will know Awakenings, as written by Oliver Sacks, waking up or rescuing patients with their post-encephalitic Parkinsonism with L-DOPA. You can see here Judi Dench in the play A Kind of Alaska, written by Harold Pinter, based on Muriel Hewitt, an actor who had encephalitis lethargica. So this was an illness that affected many people. What are the potential links to encephalitis lethargica? Well, we haven't really seen encephalitis lethargica now since back then. My colleague Andrew Lees and Robin Howard did describe 4 cases, 3 of whom had the somnolent ophthalmoparetic form, and including in the post-mortem saw what von Economo and his pathologist colleague Richard Wiesner had shown of a poliomyelitis, what looked like a viral encephalitis in the brainstem, though in Andrew Lees's case also into the cortex, but a virus was not found, and even recently here was not found, including with PCRs. Of course, we now have sequencing and other effects. Again, now 9 months after this pandemic, we haven't seen a vast outbreak of syndromes like encephalitis lethargica. So we hope that we won't see such a phenomenon, but we do know back then that the onset of neurological disease can be delayed, and of course we do need to look out for this. I recommend wholeheartedly a book by Paul Foley, a historian in Sydney, who's really described the literature that described encephalitis lethargica 100 years ago. It is biased to the European and American literature, and I do have the sense that there are many stories that are lost from China, from India and other places where we had very little literature in encephalitis lethargica. There were some reports from China, And I also recommend this book by Joel Walensky, which includes self-reports of people who had encephalitis lethargica, including physicians. But I do think one of the things that we can learn from encephalitis lethargica is not necessarily the disease, but how to deal with pandemics and pandemics that are linked with neurological epidemics. And there are many lost voices of people who had encephalitis lethargica, but also of the researchers and clinicians who looked after the patients. So we all know about von Economo, but we have forgotten and need to rediscover the work of, for example, Josephine Bicknell-Neal, who was part of the Mattison Commission in the States in 1929 and wrote a really definitive account in the 1940s of encephalitis lethargica. And it's important as well now not to forget that it's impossible to take away the link between pandemics, politics, and illness. And there are the stories of Felix Stern and Hakon Sethra, who also studied encephalitis lethargica, but both died under the Nazi regime. Felix by his own hand. Patients with encephalitis lethargica and physicians were in many cases murdered in the Nazi regime, and encephalitis counted as something that was highly discriminated against. And this book really shows how individuals and societies can challenge these common themes. So I just want to finish off and thank everybody. This is really a team effort. And within UCL, at least, we have the chairs of our MDT, including Hadi Manji, Patricia McNamara, Laura Benjamin, colleagues in infection, including Emma Wall, Rob Haderman on the line now, and other mentors, including Angela Vincent, Ava Easton, and colleagues. So thanks very much, Tom, and everybody.
Thanks, Mike. That's a great talk. If you want to just stop sharing your screen now. And I would say to everyone, please post any questions into the chat or put questions on the Q&A function. And we have a couple on the Q&A function. I think you mentioned one of them on your way through, Mike, but just this one about brain hypoxia and how much of the manifestations are from brain hypoxia versus and long ventilation parameters, septicemia, secondary infection versus the disease pathology, pathophysiology itself. What do you think about that? It is obviously an ongoing question.
I think this is an ongoing question, and that we now need to definitively study some of the new patients coming through and keep the research going. So the encephalopathy patients certainly look like a septic encephalopathy. There are theories that many of these patients that were seen in hospital had, profound, prolonged hypoxia on their oxygen sats when they came through, some imaging similar to divers or even altitude sickness. But I think, we're speculating a lot, and we need to really improve our imaging, blood and CSF biomarkers now.
Another question from, this is the same person, Vasundhara Rangaswamy. If the brain damage is also not from worsening of a comorbid condition like hypertensive stroke, etc. Actually, I guess that's the same question in a sense, isn't it? It's just about disentangling systemic disease, comorbidities from disease due to the virus itself. So maybe I'll move that question on a bit which is to the key question. You kind of hinted at it with the discussion of organoids, etc., about how much of this damage is due to the virus itself. How much we've seen viruses in the brain, but is it in the neurons? Is it replicating in neurons as, like a decent virus would, like herpes simplex virus or Japanese encephalitis virus, a virus worth its salt?
Yeah, it's probably worth its salt, isn't it? And I think we've been very quick. I mean, this is the problem with all these rapid reports and research, and we have also felt the need to pronounce on many of these things. That initially, when we saw the ADEM-like features, they were not really like many conventional ADEM patients, and the GBS and the timing, it seemed to be post-infectious and immune. But of course, there could be virus in there, and we know there are many other viruses where you don't see the virus in the CSF, but the brain can be packed with virus. And it's very difficult to do brain biopsies and to handle this. So I'm not ruling that out. I think the virus particularly with these other reports, I'm sure it is infecting the brain in some people. That, however, can cause a lot of anxiety in lots of people out in the community to say, you know, you've got brain infection and you've got ongoing brain infection. So I think we really need to get a handle on this soon and try to, you know, get some more, make sure we apply for joint research funding to really tackle all this.
Yeah. I mean, I think you mentioned the organoids, and of course, I think in those organoids, the neurons are infected with virus, aren't they? So yeah, because I'm doing a review. I'm doing the year in review for Nature Reviews Neurology. So I looked at this again, and I'll stick my neck out. I think although we get virus in neurons in those organoids, I'm not sure they are such a good representation, because I think in the brain mostly, where we are seeing virus, including the German series you may have seen in Lancet Neurology, I suspect virus is mostly in vascular endothelial cells or in glial cells rather than neurons themselves. But you know, I'm happy to be proved wrong. Let's see, are there any other final questions? I've got one from Ava Easton I'll come to in a second. Let me just deal with this last one on the Q&A, which is from Vashinka Singh. What parallels can we draw and what can we not draw between COVID-19 and encephalitis lethargica? If you want to give your top parallel to draw and not to draw.
So for me, to draw is that we should be vigilant, and that we should, you know, as neurologists and healthcare workers broadly and society, we shouldn't forget all the stories of what's gone on before. There's so much there to learn so we don't make the same mistakes. What can we not draw? I think it's premature to say we're seeing the same disease in encephalitis lethargica. And actually that disease itself was never really definitively described, and it's probably a mixture of things. You'll remember Russell Dale looking at pediatric dyskinetic encephalitis lethargica. Many of those patients had the NMDA receptor antibody. So we need, you know, all the buzzwords of precision medicine and to really pick off exactly what's going on in our patients so we can give them the best treatments and rehab.
Thanks. I mean, encephalitis lethargica is the one thing we've not seen. You know, pretty well everything else has been described, and it's the one that everybody's excited about and looking for. I guess we may see something similar late. Maybe it's a bit early, but just because it's a respiratory virus doesn't mean it has to cause the same problem. Now, Ava Easton says, how likely do you think, Mike, it is? Actually, no, so we have kind of covered that, Ava. It's this encephalitis lethargica thing again. Maybe we'll move on to the question from Avi Nath, which is about how much the long haul COVID overlapped with ME or CFS, chronic fatigue syndrome, myalgic encephalomyelopathy. How much overlap do you think there is? And is there an organized effort to study this?
Yeah, thank you. So I think this is really challenging and far too early, of course. You know, the definition of the long haul syndrome is manifestations persisting after several months, and so we're really in an early stage here. I think there will be some parallels, but we can't say that this is going to be the same as ME/CFS, and I think we do need to listen to patient voices and people who've come through the illness. So my own view, and what we're also doing, is to look at patients, listen to them and investigate them, look at their hearts, look at their brains, nerves, autonomic systems. Certainly colleagues including Tim Nicholson are very much looking at this, and I think there will be a need for a combined approach so that we don't forget, however, that there can be psychological manifestations, post-traumatic stress disorder and anxiety. So I wouldn't say it's the same thing, because you can lead to problems with clinical services. For example, then you have commissioning services saying, well, these patients don't need to see a doctor, they don't need to have any tests or see a neurologist, we should just go for psychological approaches and graded rehabilitation. But also we shouldn't be so biological that we refer patients from cardiology to neurology to autonomics over a year, have lots and lots of tests and ignore their mental health. But there are patient-related groups, Body Politic and others, but this is something we're interested in looking at, and I'd recommend you contact Tim Nicholson and King's.
Yeah, I would add, if I may, that there is, Avi, a really nice review that's been done by it's a good example. So Ava Easton, who had the previous question, is one of our partners. She's the chief executive of the Encephalitis Society. But with long COVID, I think it's proving to be a good example of the medical and science profession working with the patients. So this review, I'm going to post into the chat the link to the review by the NHR, which has been put together both from people with long COVID and the academic community. And they draw they describe this as an overlap of 4 overlapping syndromes. So there are people who've got problems post-intensive care, which we see in any intensive care patients. The second group are those who've got damage to their organ systems caused by COVID. That might be chest, it might be kidney, it might be brain. The third group, they say, are people with an ME-like syndrome. And then the fourth group are others to be determined. But anyway, that's quite nice to have a look at. I think we better stop. We've gone over slightly, but I think it was worth it because we've had some really good questions. Am I going to squeeze this last question in? Okay, last one. It's a quickie, but I think it's a nice teaser. It's from Maria Vittoria Mattoli. Should we be looking for not post-encephalitic Parkinsonism, but a post-encephalitic anosmia in the COVID-19 patients? Is that going to be the equivalent for this disease, do you think?
Well, it's hard to disentangle from the anosmia that you get early on. And but yeah, we should look for everything. We shouldn't prematurely close off any avenue of endeavor or research. This is where all the insights will come from. But I think we should look for Parkinsonism too. Of course, there have been a handful of cases, and then all the research into Alzheimer's and Parkinson's, a lot of it's very interested in inflammatory cascades, as you know.
Yeah, brilliant. Well, thank you, Mike. Let me let you all know that we've posted the link to the survey. We want people now to click on that survey, and just before you go off to your next Zoom meeting, find the survey. It only takes 5 minutes to complete, but we want feedback on this meeting so that we can make it even better than it currently is. Thanks to Mike Zandi, to Ajit Sivadasan, to all our colleagues who've joined the webinar from around the world. And I can't remember the date of the next one, but they happen approximately once a month. So thanks for joining us, and we will see you at the next one. Priscilla Rupali as well, thanks to her. Please do the survey. Bye, guys.
Thanks
Very much for joining. Bye now.